good afternoon, everybody, and welcome to the webinar of the Geriatric Emergency Department Collaborative. We're so happy you can be with us. My name is Don Milady. I'm an emergency physician at Mount Sinai Hospital in Toronto, Canada, and I'm one of the core faculty of the Geriatric ED Collaborative. Today, we're continuing our series of webinars, which we've been doing about every 6 weeks, on core topics that relate to how to create a geriatric emergency department. Today's webinar is on the topic of observation units in the geriatric emergency department. We puzzled for a while as to what to call this because we know that observation unit is not a term that everybody uses everywhere. Obs unit, frailty unit in some places and countries. We call it in Canada a clinical decision unit. Can be called the geriatric ED unit, the hold overnight place. Whatever you call it, it's generally meant as a place, whether virtual or real, an actual separate space, where an extended or enhanced assessment of the older ED patient takes place in order to determine the most appropriate disposition plan. We want to hear some different perspectives and approaches to making this work, including internationally. And if you're thinking of getting one started, I hope you'll get some guidance from this. We've got a diverse audience on the webinar, as you've already heard, many states, many provinces, and many countries represented. We've got clinicians and administrators from emergency departments. We've got healthcare system planners from across the United States and around the world. And we've got four, well, as it happens, three excellent panelists whom I'll introduce shortly. Next slide, please. The Geriatric ED Collaborative is a network of community and academic emergency departments. We work together to define best practices in geriatric ED care. We have a function of educating ED clinicians about models of care to improve the care of older people. We support emergency departments and healthcare systems to implement those models of care, and we research and evaluate outcomes. If you share our vision, your emergency department can join us, and currently for free. We're putting the link for membership in the chat box, and you can see it there. You can check out our website at gedcollaborative.com. You can follow us on Twitter at the GEDC. And since December 5th, 2 days ago, represented the 6th anniversary of our first boot camp at Aurora Health Systems in Milwaukee. You could also send us a birthday card. Next slide, please. We couldn't do the work that we do without the generous support of our sponsors, the John A. Hartford Foundation and the Gary and Mary West Foundation. Thank you very much to both of those foundations. Before I introduce the panelists, I just want to make sure you all know how to use the Zoom platform. All of your microphones have been muted. That doesn't mean we don't want to hear from you. We do. We want your comments and questions. The best way to communicate is through the chat option. To find the chat box, follow these instructions. Hover your mouse over the screen. You will see 5 icons, usually in the middle bottom of the screen. Click on chat. I'd suggest that you leave the chat box open through the whole presentation so that you can keep track of the comments. If you're going to make a comment, and we'd invite you to do so, make sure that participants is selected. You will see, I'm not sure I'm giving the right direction there. Yes, please select panelists and attendees. Otherwise, the comments will go only to us. So as we get started, I've got a question for all of you that I would like an answer to. Can you just put into the chat box, tell us where you're calling in from, hospital, city, state, country, and tell us whether you have an observation unit at your emergency department. If you're not sure, just say not sure. And as we go along, if you have links to resources or innovative things or suggestions that you think might be helpful to the other participants, just put them into the chat box. The webinar is being recorded, and a link to the recording and the slides and the chat box will be available on our website tomorrow by around noon. And you can freely access it there. Next slide. I would like to start by introducing our, if you have technical difficulties, you might actually want to get out a pen and write this phone number down, because if everything crashes and falls apart, you can still text Laura or Connor for some assistance on how to get back. Next slide. Our first, so this is the title of our talk. Our first panelist is Dr. Stephen Meldon. We're so pleased and honored to have Stephen with us today. He's the academic chair of emergency medicine at the Cleveland Clinic and the Lerner College of Medicine at Case Western University. He co-directs the Cleveland Clinic Geriatric Care Unit, which was recently accredited as a level 1 geriatric emergency department. And he's been a leading figure in the field of geriatric emergency medicine for nearly 2 decades. And to give evidence of that, I just want to hold up this for all to see. This was the first textbook of clinical geriatric emergency medicine, which Steve and his colleagues published in 2004. So we've got a lot of experience speaking there. Next slide, please. Jay Banerjee is a consultant in emergency medicine at the University Hospitals of Leicester in the United Kingdom. His job is totally dedicated to older people in the emergency department. He's the director of the Geriatric EM Fellowship there, and until recently was the chair of the Geri EM group at the Royal College of Emergency Medicine in the UK. Interestingly, Jay is also fellowship trained as a pediatric emergency physician, but currently his job description allows him to see only people over the age of 65. Unfortunately, Jay is indisposed with a tooth abscess, which prevents him from talking, which is a very unusual state for Jay to be in. And so the co-presentation will be done exclusively by, next slide, please. Simon Conroy is a geriatrician, also in Leicester, and a collaborator with Jay in the UK. He works in the frailty unit of the University Hospitals of Leicester. He focuses on bringing evidence about people living with frailty to clinical practice. He's been involved with the Acute Frailty Network in a project called the Silver Book, of which the international version, of which many of us are co-authors, is just about to appear. And finally, our last presenter is Dr. Lauren Southerland. Lauren was the director of the Geriatric ED at Ohio State University when it was accredited as a level 1 geriatric ED. She's currently the director of clinical research at Ohio State. She's a full-time, full services emergency physician. She sees all ED patients, but she tries to scoop all the interesting patients over the age of 65. So those are your panelists for the day. Next slide, please. I'm going to hand this over to Steve to get us started. Steve, can you tell us about the geriatric care unit, your OBS unit at the Cleveland Clinic, and how it functions?
Absolutely. So Don, thank you very much for that introduction. And it's my pleasure to be here to talk about how we set up our OBS unit to care for this population of patients. Next slide. So first, just a word about Cleveland Clinic main campus, ED. We are a busy urban academic medical center, 67,000 visits in 2019, and about 1/4 over the age of 65. Fairly large ED with 64 beds in 3 separate pods. We have a long-standing and very high-functioning ED-based observation unit, which we call our CDU, Clinical Decision Unit. It has 4 beds dedicated to our geriatric care unit, but the ability to flex up to as many beds as we need, up to 14. There's dedicated RN staffing to this unit. The unit is staffed by advanced practice nurses who have both acute care and some geriatric experience. And there's assigned emergency medicine physician backup. It is an ED run unit and in very close proximity to our main part of our ED. Next. So the one advantage of having an OBS unit is that we can tailor admit orders and order sets to this unit. We've also developed geriatric consult orders. Generally, it's a 23-hour stay unit. However, we do bend that rule when we need to. We don't discharge people at 3 in the morning just because the 23-hour clock is run up. Our care model really has always included case management and social work support. I think case management is critical, especially for transitions of care. They do jobs that I simply don't have the time, the expertise, or the relationship to do. We have ED pharmacists 24/7, and they do medication reconciliation for this unit and also help with medication appropriateness. Physical and occupational therapy are available and easy to consult. After piloting this about 2 years ago, we actually had placed an embedded geriatrician in the ED and the CDU to just look at viability and workload. And that led to actually placing a geriatrician in our ED in the GCU, as you can see, Monday through Friday. Now, interestingly, although we are an OBS model, this is almost kind of a hybrid because we can also get ED consults, whether the patient is being admitted or discharged, really depending on the workflow, the ED and GCU census, and how much other things are going on at the time. Next. So some photographs, appropriate signage. What's nice about using existing observation places that it's private rooms, it's quiet with the enclosed doors. For geriatric ED accreditation, we really needed just to put modifications in a smaller number of rooms in really a limited space, which I think was also helpful versus an entire emergency department. Next. So I think patient selection is critical and key. We really want to impact patients that can benefit. So hypertensive intracranial hemorrhage, getting admitted to the neuro ICU, not so much. So we developed some high-risk criteria, and we've done a couple things. One, we have delirium screening in triage for anyone 65 years or older. We also then just developed high-risk criteria, which you can see listed. Some based on age, but also polypharmacy, frequent falls or a history of falls, multiple ED visits, and history of dementia. We've really put all that into our electronic medical record. We use the Epic platform, and Epic actually pulls this information out and then can automate that banner you see below where it says high-risk geriatric criteria met. That then links to our geriatric consult order. So once again, it's just a way to keep awareness for our busy ED docs. We also have the banner above, which shows the delirium screen is positive, and with some suggestions about that also. We chose not to use other screening tools such as ISAR or TRIST, and instead kind of built these based on our experience, based on what the literature has said about the specificity and sensitivity of screening tools. Next slide, please. All right, so I didn't mean to show everyone an eye chart, but I really wanted to point out that I think if you're developing a complex workflow, one of the key things you can do is map it out. Map out your workflow, draw a process map where everyone can be on the same page and really understand what can be complex processes. So I think, you know, the details here are less important. However, you're welcome to peruse it. But I think the process is more important of really mapping that out and saying, what do we do when the patient shows up? What's the next step? Who does what? And you can see the swim lanes have all the applicable people that would participate in the care of the patient. Next. So I just wanted to go over a couple patient stories and just kind of review this. So we have an 87-year-old with prostate cancer. He has poor functional status. There's some question of whether, you know, what his wishes are. We have a 98-year-old, hypertension. He presents with falls and generalized weakness. And, through assessment, you realize that he's really unable to live alone at home. Next. 69-year-old, hypertension, diabetes, hyperlipidemia, very common, obviously in Cleveland or anywhere in the United States, presents with syncope. The geriatric assessment finds polypharmacy and adverse drug reactions. And then an 85-year-old with dementia, AFib, hypertension, well known to geriatrics, who presents with failure to thrive. And here, the assessment reveals advanced dementia and really gets to discuss goals of care. So why did I share these? I think, one, there are just cases that are unfortunately all too familiar. I think we would all say, yes, we have those patients too. In all these cases, our geriatric evaluation impacted the disposition. I will tell you, every one of these patients would have been admitted to the hospital without a geriatric evaluation and intervention. I think it's important to share these stories. I actually send out these patient impacts to my staff via email. We also share them in our staff meetings. I think stories resonate. And when you show some of the impact you can have on these patients, I think it's very powerful. So I would recommend that heartedly. Next slide, please. I'd like to share some of our outcomes. We looked at our program. This is a retrospective case control study with pre and post program. You can see 9,663 patients. What we found was overall admission rates were significantly lower with geriatric involvement. You can see 23%. I think that's backwards actually, but yeah, 23% post-program versus 49%. And then the CDU and GCU admit rates also very different, with the pre-rate of 23% versus 9% post-program. We actually looked at a regression model and controlled for age, gender, recent ED visits, Charlson Comorbidity Index, and ED obs placement. And what we found was when you controlled for all those, the odds ratio of being admitted was almost fourfold if you did not see a geriatrician. Same with just overall all patients, including ED patients, it was almost twofold, 1.7. We also looked at our electronic medical record because we thought that was rather novel to try to automate the best practice alerts and see if we can't drive some of those consults. So what we found is when we updated it and implemented it, we had a 21% increase in geriatric consults afterwards. These averaged about 50 a month. I will tell you, this was also during our big drop in volume due to the COVID-19 impact. So we had 30% less geriatric patients than we normally would. Next slide, please. So I just wanted to review some of our keys to success. As I mentioned, I think patient selection is critical. You really want to try to have an impact on a patient that you can. If I see an 80-year-old who's training for his 4th triathlon and he trips while running, I'm not sure how much impact I could have there. So I think that's important. I think the EMR generated best practice alerts allows the busy ED doctor to easily note that, hey, wait, this person has some high risk criteria. Provider communication is critical. We use the best practice alerts and banners. If you look over to the right, you'll see an actual screen grab of our track board, and you can see the little penguins on it. And that's basically to know that you're a geriatric consult patient or a GCU patient. That actually generates a patient list for our geriatricians, so they know who to see, whether it's in the ED or GCU setting or even as an inpatient. We think the comprehensive geriatric assessment works very well for us. It's obviously does take a big investment, but it's really works well in this setting. We're piloting telehealth consults currently for the weekend. A team approach is another key to success. I would tell you case management is a key component. They really help with the transitions of care. They really help with getting things set up that are very difficult to do in the ED setting. The transitions of care we're well experienced with. We actually have been doing this for a while. We have an ED to SNF direct transfer program because of our accountable care organization, and we're really well developed on that. We actually have about a 40-page playbook on how to do that. That has actually been very useful because it can be applied to this same patient population in our GCU. So that's been helpful. And last, the startup costs need to be covered and thought about, whether it's through philanthropy, grants, or hospital support. I think that's one of the critical things. And we'll hear more about some of the costs later. So really, in conclusion, for us, this OBS unit was ideal. We had the appropriate space. We had ED personnel we did not need to add to. It really took away throughput issues and time sensitivity and time factors. And as we've shown, it's had a significant impact on our admission rate for our older ED patients. So thank you very much for your time, and of course, look forward to discussion and questions. So thank you.
Good, thanks, Steve. Just before we move on, we have a little window of time here. I just have a personal question, which I kind of reflected in the chat. So I notice the OBS unit is staffed medically or clinically by a geriatrician or a geriatrics APN, advanced practice nurse. How much do you think the value comes from the geriatrician, and how much comes from the multi or interdisciplinary team members?
Well, I would say if you look at some of our outcomes, what we found, we actually looked at that using the same team members, case management, APNs, emergency medicine physicians. We really had, more than twice the admit rate. And then when you add in the geriatrician, that was the impact. And that's why we controlled for that in that logistic regression model. And really to look at that and try to isolate what was the impact of a geriatrician in-house.
Good, that's very interesting. So I just launched a question back out into the chat there. I noticed many people on the line do have observation units at their place. Could you just put into the box who is the main responsible person? Is it an emergency physician? Is it an emergency case managing nurse? Is it a geriatrician or somebody from internal medicine? Be interesting to see the variability around the world. Thanks very much, Steve. There'll be more questions for you after the other presenters. And at this point, I'll turn it over to Simon on his own, presenting for himself and Jay. Simon, how are things different in the United Kingdom?
Thanks, Don. Well, it's really interesting listening to Steve's talk there, because I was just reflecting that so far away, yet so much the same, because a lot of the stories that are being shared there echo our own experience. So there's probably some sort of universality to this role and this function that we can draw upon and perhaps think about how that has resonance across not just Western systems, but perhaps more widely. But so just to sort of explain a little bit about sunny Leicester, if we go to the next slide. So Leicester is a small town in the heart of England. You can see in the red dot there. It's famous for its sporting teams. There's a soccer team, a football team, and a rugby team. Rugby, for those of you not familiar with it, it's a bit like American football, but played by grown-ups. But they're not doing so well at the moment. It's also famous for its history. So we found a few years ago the bones of one of our great kings, Richard III, buried in one of our car parks. So we don't just have any old car park, we have historical car parks, and famous as well for its culinary delights, in particular curry, which is a great favourite of Jay's, who sadly can't be here tonight because he's got a dental abscess and can't talk, which, as Don said, is an unusual phenomena, but he's given me his blessing to talk about our efforts over the last 12 years or so on his behalf. So if we move forwards, please. The journey started about 12 years ago, so you can see here young photos of Jay and myself. Those of you that are familiar with both of us will recognise that things have changed a little bit, not only in terms of our appearance, but in terms of our thinking as well. And I know we need to focus on the OBS unit tonight, but one of the things that I will just touch on a little bit is how this is a journey. It's a long process, an evolution in our thinking over time, and how we've would have done things differently if we had started where we are now, if you see what I mean. So we were both relatively young consultants. Jay's a few years ahead of me, so consultant being a sort of qualified, certified specialist, Jay in emergency medicine, myself in geriatric medicine. Initially we were working on different units. So I was upstairs on what was called the acute medical unit, I guess the acute receiving unit. Jay was downstairs in the emergency floor. But we were both bound together by our shared passion for trying to improve outcomes for older people, recognising that the status quo where we work, and indeed across the country, could be so much better. So if you go to the next slide, the initial efforts were slightly separate. So I was trying to embed frailty attuned care into this acute medical unit, so a service run by physicians. This is post ED, so patients usually will have been through the ED. Ideally should have been moved on within 4 hours. That doesn't always happen, increasingly less frequently these days. But so this is a physician-led unit, big service with some 50-odd beds at the time. And I was trying, recognizing the need to embed geriatric or frailty attuned care within the medical take, was spending a lot of time and energy working with my physicianly colleagues upstairs to try and get them thinking differently. I think we recognised that we needed to do some culture shift. This is a story of kind of relationships, both positive and negative, and trying to change cultures. So some of our language was kind of purposefully provocative. So we used the notion of frailty, which was often used as a rather negative and derogatory term, certainly in the first few days. And I remember people laughing at the concept of an acute frailty unit, whereas that's now quite common currency, certainly in England, and of course ties in nicely to the concept of frailty, with which I'm sure many of you will be very familiar, which is an important underpinning principle behind all of our service developments over the years, is to address frailty and complexity. So despite probably a year or two of education, training, frontline leadership, role modelling, clinical support, constructive clinical challenge, working with my physicianly colleagues, we really didn't shift the needle very much, and had still a paucity of end-of-life discussions, medication reviews, and overall holistic assessment across the spectrum of older people's care. So this wasn't just about me or a geriatric team. What we were trying to do is change the practice, or develop the practice of our physicianly colleagues. And Jay was doing similar things downstairs. He was leading at least a lead player in what those called an emergency decisions unit, an observation unit, which had 16 beds, much of which was about older people living with frailty. So 50% of those patients being managed there were older people, many of them coming in with falls and relatively minor injuries, a somewhat ambulatory population, despite which very high admission rates, which probably, and we can discuss more later, reflects the uncertainty with which our emergency physician colleagues at the time had in managing older people with complexity. Next slide, please. So having tried me upstairs, Jay downstairs, to sort of develop the service offer, we eventually managed to fuse that and combine our efforts, and created the emergency frailty unit. And again, language is important here. So frailty being part of the brand that we were trying to push to create this different culture and thinking around the notion of frailty. And the juxtaposition of emergency frailty wasn't an accident either, because working together on this emergency unit, or emergency decisions unit, we came to recognize that we really needed to have both sets of skills, very much in keeping with the geriatric emergency medicine tradition. So the emergency decision nurses, brilliant at rapid discharge, rapid assessment, obviously all the emergency medicine related competencies, particularly around trauma and injuries. The more frailty attuned team, and I'll describe those for you in a short while, bringing that more holistic assessment with some specific underpinning geriatric competencies, particularly focusing on polypharmacy, cognitive assessment, and prognostication. But what was perhaps slightly, it certainly was different at the time from the UK context, was that we literally made the geriatricians and the emergency physicians work together on this unit hand in hand. So there would be emergency physicians doing a round as well as a geriatrician doing the round. Some would be on just their own patients, but there would often be shared patients where we'd do joint consultations. Particularly you can imagine around silver trauma and conditions such as that, where having both perspectives was really powerful. And of course some of that is related to the clinical needs of the patient, but it was more about developing the relationships, shared common goal, shared way of thinking. And that really strengthened the relationship between the emergency physicians and the geriatricians, to the point that when we started to get into turf wars within our hospital about, the physicians wanted to come down to this unit and take it over, and then we sort of ganged up with the emergency physicians to fight them off. I'm sure you have these fights in your own settings, but the relationship that built up over the years between the geriatricians and the emergency physicians was really strong and really important, and I think has really stood us in good stead for the changes that we've made over time. So yes, for sure, the geriatrician being involved downstairs did add some value. We reduced the conversion rate or the admission rate from the emergency decisions unit. But as importantly, if not more so, there was also, in the way Steve was describing, a consultation function reaching into the majors area. So we would do our EDU ward round, which would take a couple of hours, and then spend the rest of the day dedicated to supporting the ED, seeing patients in what we call the majors area, providing education, training, support. And this was with the ambition of trying to impact not just upon that relatively small proportion of older people that hit the emergency frailty unit, but actually to address care of that older population across the whole of the across the whole of the emergency floor. And if we go to the next slide, you'll see that we managed to achieve some important improvements in service metrics. We never really got the opportunity to evaluate this robustly from a patient perspective, which is a shame. But you can see here, this is data which shows outcomes for the whole population of people over the age of 85 attending our emergency department. So included in there, those that were on the emergency frailty unit, but the metrics presented reflect the whole population. So overall, we got around about a 10% reduction in admissions for the 85 plus population, which is probably meaningful. Certainly, I think our hospital would be delighted to have such sort of reductions in admissions in the current times that we're all facing. And pleasingly, we didn't observe a significant increase in readmissions. In fact, our readmission rates went down for the most part. And that's related not just to the clinical assessments in terms of optimizing people for discharge from the emergency floor, but also work that we were doing with community partners to make sure that the whole system had a frailty attuned response. Next slide, please. And onwards and onwards. So I touched upon this being a journey. We've learnt over the years so much. We started with ISAR, we started with falls pathways, we started with age-based criteria. We've tested all of these different ideas, moving through to the concept of frailty. We've tested an emergency frailty unit. We've looked at the whole kind of front door response. And we've of course worked on the workforce, or developed the workforce, because we completely accept that this is not just about geriatricians or emergency physicians, but the wide range of other important members of the team. So frailty nurses, we used to call them primary care coordinators, but essentially gerontological nurse specialists that could help with the holistic assessment. Of course, therapists, pharmacists, but over the years also we'd worked with some excellent people, some of whom are on the call tonight. Hello, Rosa, who spent some time developing emergency physicians developing their skills in geriatric emergency medicine. We've also had a geriatrician who did this GEM fellowship with us, and Sarah developed her skills in emergency medicine and trauma and kind of resuscitation and managing or assessing undifferentiated patients. So it's always been this philosophy of a shared approach. As the service has developed over time, we now have kind of a so-called frailty emergency squad, so a multidisciplinary team that roves around the emergency floor, which means that the frailty unit is actually more of an admitting unit now, because we've kind of front-loaded that assessment. So most people who can go home are going home from the ED majors, which means that the sort of role for the observation type ward is not completely gone, but diminished. Because we're getting many more people home from before they even get to the unit. And more recently, we've been doing some more outreach, which we can discuss more if there's time towards the end, supporting the paramedics with their decision making, particularly in older people from care homes during the COVID pandemic. Next slide, please. So at the moment, there's a big focus on ambulatory care or same-day emergency care, and policy and practice both locally and nationally in our country is about trying to point that towards older people living with frailty, recognizing the benefits for them associated with avoiding unnecessary and unwanted and often unhelpful hospitalization. But also the system benefits as well. Don't admit to people if you don't need to, makes a lot of sense. A lot of efforts in education and training, involving relevant competencies from across the workforce, palliative care, continence nurses, alcohol support, etc., etc. You can see the list there. So a pluripotential model of staffing, which again adds to the skill mix and the competencies that we're able to apply to older people with crises. Next slide, please. And then just touching briefly on where this goes. So we did some work on the Silver Book, I think 2012. And as Don mentioned, we're refreshing that now with an international version, which we're really excited about. And many of you have been involved in that, which has been great. So we're trying to support the GEDC movement and collaborative and spread this message internationally, because it does seem to work both for patients and for the system. And we've been involved in a lot of national quality improvement initiatives, some of which are listed there. We can go into more detail later if you wish. But I will pause there for now as my time is coming to a close. Thank you for listening. And if we have time, we will take some questions, perhaps, Don.
Good. Thank you very much, Simon. Very interesting. And I am struck by how similar the two services are in the two countries. There are a number of themes developing in the chat box, but let's leave them for the very end, and I'll move on to Lauren, who I know has a slightly different model at her place, but she's actually going to show us the money and talk about some of the finances involved with running an observation unit. Lauren.
Thank you, Don and Simon. I am just chuffed to be following my mate, Simon. And that's about all the British that the Great British Baking Show has taught me. So I won't force more upon you. My goal.
Doing simultaneous translation in the chat box.
This is going to be, if you bear with me, a very American health-centric lecture, but as you noticed by the two prior discussions, the core of what I'm going to tell you applies everywhere. No matter what health system you're working on, finding the money to pay for the interventions you want to do is always the critical part to convince your administration and your department to do something like this. So next slide, please. So when you are thinking about whether or not you want to design a geriatric OBS unit or short stay unit, what you'll notice from both of these prior presentations is that they had a unit in place, basically, that they then adapted. And that's the way to go. I would not recommend that you say to your administration, we want to start an OBS unit just for geriatric accreditation. It's a lot of work to start an OBS unit. There's a lot of things going on, and it only makes sense if it makes sense for your ED flow. So you really have to sit down with your multidisciplinary team and write out swim lane diagram like Steve Meldon showed you, exactly who's doing what and what's going on and what the impact is going to be. And a nice thing that Simon pointed out was that they started with it as an OBS unit, but eventually reached out into the ED and eliminated the observation stay for a lot of patients if they could get that done during their ED time. And that works great if the majority of your patients are coming in from 9 to 5. But if your ED is like ours, where our peak time was more that 5 to midnight when we're seeing all these patients coming in, getting your geriatricians to come in at 10 o'clock in the evening to see patients was not going to work. So holding the patients to be seen the next day worked well for our functions. So next slide. And you have to think about an observation unit financially. So in the US, You bill for the ED visit, and then you can also bill this additional observation stay code, which pays for that extra time that they're getting placed and seen by the doctor. And then any additional assessments on top of that, if they see physical therapy or a geriatrician or other things, get a cardiac MRI, whatever you're doing in your OBS unit will be billed out separately. So this group led by Chris Bow did a Monte Carlo simulation of billing and found that no matter how you cut it, your observation unit is probably not going to be financially stellar. Most likely you're going to break even if you're lucky. And if you're not, you'll need some buy-in for your hospital administration to cover those extra costs. Next slide. And what are those costs are, is you have to have dedicated nurses, a dedicated area, attending, usually an ED attending or an ED trained APP to cover those. And then you have to give money to all these other people to help with this multidisciplinary assessment. It's easy to say consult occupational therapy and pharmacy and geriatrics, but they have to have systems in place to bill. So kind of going one by one, when you're designing your unit, you have to work with them. So your Department of Rehabilitation may be able to work with you to have physical therapists, occupational therapists, or speech therapists come down to your ED, and all of those practitioners can bill independently. So they'll come down and help you, but then that money goes back to their team or their department. So while your health system makes a little more, your department is still paying costs for the unit and everything. Similar is your choice of a geriatrician consult team. A lot of places initially started using geriatric trained nurses or nurse case managers, but in the US, you can't bill for that extra time. And anybody who's ever done a geriatrics consult knows that it's not a 20-minute in and out assessment. Oftentimes these assessments will take the practitioner an hour or 2 hours by the time you call the nursing home and the family and get an up-to-date med list and everything. So what a lot of people are moving towards is a geriatric nurse practitioner or geriatrician consult team from inpatient that can bill independently. And if you're having these teams come down, you want to make sure as you set up your unit that they're coming and seeing your patients first. That's critically important, because if your physical therapist doesn't assess your patient until 3 o'clock in the afternoon and then says, we need to set up some home health and they need this equipment at home and a raised toilet seat and grabber bars, then your case manager won't have much time that day to get all that set up. And you now have to keep them another day to get everything set up for them to go home. So when you set up your unit, you need to talk about how are you going to bill for it, and make sure that you have the commitment that these teams are coming first thing in the morning and seeing your patients first. And you can prioritize that, because if they clear out the OBS unit, then you can backfill that with ED patients and start to decompress the ED more. So it's an easy argument to make, but you want to be sure that's made up front. Two other common members of the multidisciplinary team are your pharmacists and your case managers. In the US, neither of those bill independently. Pharmacists can bill for MedRec for a limited number of situations, but otherwise their time is just covered by your hospital. So you need to argue for the amount of time you need. And I would argue that any OBS unit needs a full-time case manager to really do home safety assessments, set up all the appointments, get these older adults that are safe to go home and they're not just admitted for further care to sort them out. So if you want to design a unit that's really going to decrease admission rates, like Simon and Steve have shown you, you need the staff and you need the funding and administrative buy down from your hospital system to do that. Next slide. So you may say to me, well, Lauren, aren't you just seeing all your patients as walking money bags? You're going to come in and do all these assessments and then bill them for all this different stuff. And the answer is no, that's not what they are to me. But to make your unit independent, you need to have these systems in place. And you need to understand the billing, because it's also critical to the patient's understanding. Next slide. So in the US, about 5 years ago, there was a big problem with this concept of observation. And the reason is because there are multiple different parts of Medicare, which is the government-funded health insurance that covers adults 65 and older in the US. So Medicare Part A covered inpatient costs and Medicare Part B covered outpatient costs. And OBS was this weird thing in the middle, and they lumped it into outpatient. And what would happen is a hospital would put someone as OBS status saying, well, you don't need more than 2 nights in the hospital, so you'll be OBS. And they wouldn't switch them over, and they'd stay as OBS status for 3, 4, 5 days, get discharged from the hospital, and be billed the outpatient costs of everything instead of having it fully covered under their inpatient deductible. So there was a lot of fear at the time that this would happen. And you may see that from your patients saying, I can't go to OBS, my insurance won't cover it. Your insurance will cover it. These bad practices in some hospitals have been fixed. They've been fixed in all hospitals, but they were only in some hospitals doing this manipulation of OBS versus inpatient. So next slide. And research study after research study has shown that ED-run OBS units, when they have a dedicated team, a trained team, dedicated protocols, save money. They save money to the health system, and comparing patients with the same comorbidities and problem coming in, an ED OBS unit is going to get you the same care for cheaper than an inpatient stay. And that's just because we get everything done quickly. And we can turn patients over in that 10, 12, 14 hours, whereas upstairs, they see the doc in the morning who rounds, and then sometimes tests are done in the afternoon, and maybe they'll be done the next day, but they're definitely not drawing blood work at 10 p.m. and 4 p.m. to make sure their potassium's improving and we can get them out in the morning, like we do in the ED OBS unit, because we're awake, so we take care of it. So you can assure your patients that whether they're in an inpatient bed or an ED bed, they're still going to be observation status if they meet observation criteria. They're not going to be hit with a humongous bill for a 5-day observation stay. And 90% of patients will pay less out of pocket in an ED OBS unit than they will admitted. Next slide. And so when you see these questions from your patients, you can reassure them financially, it is what it is. I wish I could fix the American system, but I can't. But if you don't want to stay in the hospital, our OBS unit will get you in and out faster and get the tests we need done faster. And the other question I get from patients is, why do this in the ED at all? Why can't I go home and just have your case manager call me for my appointment for physical therapy and occupational therapy and geriatric cognitive assessment clinic? Definitely I can arrange that if someone really doesn't want to stay overnight. But what we know is that 80% of people don't even follow up with their primary care doctor after an ED visit. So arranging another 4 visits on top of that is unlikely that they're going to make it. And everyone else with an OBS unit can express their own feelings, but anecdotally, patients and families have been so happy to get everything done before they leave. And a lot of times arranging all of this from home and working with their primary care physician, especially now during COVID when they can't even get in to see anybody or get in to get lab work or tests done easily, patients and families have been really happy to get this multidisciplinary geriatric assessment done in the OBS unit. Next slide. So what I want you to think about and take away from this is, if you're looking at the OBS unit model and you have an OBS unit, that's great. You already have a lot of systems in place. It's not that much more difficult to add on these different protocols. Work with your multidisciplinary teams to get all this done. However, if you don't have an OBS or short stay unit in place, and doesn't fit in with the objective of your hospital administration, so that they're going to invest a lot in you and your unit, knowing that setting up an OBS unit takes at least a year to do, if not more, there are lots of other ways to make your ED geriatric friendly, and this might not be the right one for your hospital system. And that's the great part about the geriatric ED guidelines and accreditation, is that you tailor it to what you locally need. And it's interesting to see the different solutions to problems that everyone comes up with. And then you really need, I would say, written agreements in place with all your multidisciplinary staff about who's seeing who, when, what, and why. And as you saw, both Steve and Simon had that. We had our diagrams. We're going to have you at this time and you at that time, and make sure it all flows. And then be prepared to have the conversations with your patients about why OBS unit is good for them, why they may need to stay there to see all these people. You know, they might say, I've been to a physical therapist before, I don't need to see him. Well, how long ago was that? 5 years when I had my hip replacement. Well, you know, you had a fall. We need to review things. Just because you saw them once 5 years ago doesn't mean you don't have a new issue now. And if you do all that and you work with your hospital, you will reduce admissions for the patients that the hospitalists and the health system like to have on the wards least, because older adults take up the most nursing attention because they're medically more complex. They need, you know, 9 to 10 medications instead of 2 to 3 and all of this. So track those outcomes. Also track, if you can, delirium and sitter use in the hospital. So I think the use of a sitter or one-to-one assist while someone's in the hospital with delirium is another way that your hospital is probably already tracking that data, so you can pull that easily, as well as your admission percentages and your length of stay. All right, so thank you very much. Hope that was helpful.
Thank you very much, Lauren. It certainly was. For those of you who have been following the chat box, there's been quite a lot of action in there, and there's quite a lot of questions coming our way. My colleague Yula Huang is putting together some of them. Just next slide for a moment, please. Wow, oh, sorry, Yula's still doing that. While we're accumulating our questions, just a reminder that you can follow us on Twitter or visit our website, and that's where you will find all of the information from today, the presentation, the slides, and the chat box. Okay, previous slide, please. Yula, over to you. Any question that you'd like? Oh, and I should just say to the audience, if you have a specific question that you would like answered right now, please text it in, direct it to the panel in general, or to one person in particular. Yula, what do you have to say?
Great, thank you, Don. I want to really emphasize and thank Steve, Simon, and Lauren for an outstanding presentation today. We had a really international group of representations and attendees. I think actually heavily outweighed by outweighing the United States. Actually, many Europeans. We have many Scandinavian represented countries, Central Europe, in the UK, Spain, Switzerland, Ireland, Finland, Belgium. Many from Canada, many from all across the United States, from both VA and non-VA hospitals. So again, thank you so much for your participation. In your responses, one of the things that I wanted to note, many of you have OBS units and many of you have indicated it's truly an interdisciplinary effort. One of the themes that we saw come out of the discussions here, though, is the value of geriatrics and geriatricians and the engagement here. I'd love to hear from each of the panelists. Well, as we also know, geriatricians are becoming scarcity. As our populations are aging all across the world, we are actually having fewer and fewer geriatricians. And so any solutions or key things you'd want to highlight about this and suggestions. So we can start maybe from each of you, or so Steve.
Yeah, I do think there's no question in my mind, having been involved with this for 20 years, that there's incredible value with our geriatric colleagues. We agree that it does take a little work to staff this because they are needed in the geriatric clinic. We were able to get some philanthropy dollars to really help offset some of that cost. So I would recommend, that's one avenue to do that. We do supplement our geriatric code director, Dr. Saxena, with a geriatric APN also. And that might be also a little way to staff it at a lower cost. I'll tell you, that's why I staff the clinical decision unit overall with APNs, because of costs. And what we've seen is outstanding quality, no fall off in that.
Simon, what do you have to say? Is it the geriatrics or is it something else?
So I think I'm the only geriatrician on the panel, so I can speak with frankness to my emergency physician colleagues. So not all geriatricians are the same. Yeah, I mean, we geriatricians fall foul of the population that they serve. So cardiology is pretty well defined as a speciality. There's ACS, there's NSTEMI, etc. There's specific conditions which have well-evidenced protocols, and there'll be some variability between cardiologists, but on the whole, they give you a fairly consistent answer about how to manage a particular condition. Older people living with frailty present with a wide range of conditions with huge heterogeneity and complexity. And partly, I suspect that underpins why there's such variation in the approach of geriatricians, because there isn't that straightforward, clear evidence-based linear approach to how to assess older people. So that's the first point. There's lots of variation amongst geriatricians, part of which is driven by the population that they serve, part of which is natural inter-professional, clinician variability. Many won't have the stomach for working in the ED. They'll be nervous, they'll be scared, they'll be used to working maybe in rehab settings or post-acute care, and managing undifferentiated patients in the ED is a particular skill set, and not all geriatricians will be comfortable with that. Our experience over the years is probably about a quarter to a third of our consultant workforce are good, whatever good means, at front door geriatrics. The others have got other strengths that are best used elsewhere in the system. So that's the first point. And the second point is, as you already heard from Steve, is that just the numbers won't stack up. So if we base the delivery of geriatric care on the presence of a geriatrician, then we're doomed, because demography is going to overtake us. Hence why we focus quite heavily on developing geriatric emergency medicine approaches where we, wherever possible, draw on combining competencies, whether it be through nurses or therapists or pharmacists or GEM fellows or whatever route we can to try and upskill the whole workforce.
Thanks, Simon. Lauren, anything to add on that point of geriatricians versus not geriatricians?
I think, as some of our participants mentioned, if you have a patient who's already seen the social worker and the physical therapist, and there's no way they're safe going home, and they definitely need admission to the hospital for nursing home placement or other things, then having the geriatrician come down to the ED and seeing that person stat in the ED is probably not as necessary. They can see them when they're up on the floor as a regular consult. But for those patients that are borderline, especially those with cognitive difficulties, with polypharmacy, with complicated home situations, the geriatricians, in my mind, are invaluable.
We have just a few minutes left. So another theme was coming out of Simon, your presentation, sounding like your observation unit has sort of become obsolete because you've got so good at managing people while they're still in the emergency department. Steve or Lauren, is there a reason why we don't just get rid of observation units and do this work in the emergency department? Speed things up, save time, save costs.
I'll jump in, and I'm sure Lauren's going to probably echo what I say. The big thing is simply time pressures and throughput. We are a busy ED, a lot of patients coming in, well, 1,200 ambulances a month, so 40 a day. It really comes down to doing that fairly comprehensive geriatric assessment. As Lauren pointed out, does take an hour or two. You've got to get things set up. And we simply need to move the patient along. I think that's actually why emergency medicine has not done as well with these patients. We really kind of get right to what we think is the crux of the matter, and we kind of don't think about the other things. So the biggest thing is simply throughput, space constraints, and that's why we took advantage of our observation unit.
Lauren?
Completely agree. I would also add on that staffing these patients. Remember, your ED flow, most of the patients are coming after hours to the ED. And so then you have to staff a physical therapist, and you have to have your geriatricians ready to come at 5, 6, 7, 8, 9 o'clock at night. And Simon will tell you, we can barely get them to come at 10 in the morning. So that's not going to happen.
Okay. Thanks very much. We're coming up to the top of the hour. There are lots more questions unanswered. Eula, any final comments?
No final comments. We are just delighted with the participation in the audience. And Don, I think we're maybe stay tuned. Every month we're going to have a future webinar. And
next slide, please. Yeah, so be with us back on January 11th. Unless the world has solved COVID completely, the topic will still be relevant. On January 11th, 2021, we'll be 10 months into the pandemic. And we want to talk about what we've learned about improving care, COVID care specifically in a geriatric emergency department. We'll be looking at various different topics. So please join us on Monday, January 11th at 3 o'clock Eastern. And wherever you are in the world. And next slide, please. As our closing slide, we would like to thank our supporters and donors, the John A. Hartford Foundation and West Health Institute. I'd like to send a special thank you to our experts, Stephen Meldon, Simon Conroy, and Lauren Southerland, and Jay Banerjee in absentia. Thank you very much for being here, everyone, and we'll see you again in a few weeks.